So let's talk about spectacle lenses. First of all, under-minusing is one of the worst things you can do. Here, there are 2 clinical trials published showing essentially the same thing. Undercorrecting kids actually accelerates or increases the progression. These are data from those 2 clinical trials, and the open symbols are the kids who are fully corrected. The black diamonds in both studies are the kids who are slightly and systematically under-minus. And you can see that there's, if anything, an increase in progression. So give the kid the full prescription. And if a parent challenges you, these are the data you should show. It doesn't do any good, and it may actually make things worse. You know, what's worse than giving the kids slightly blurry vision so they can't see the chalkboard? What about PALs? We've got remarkable consistency across most of the rigorous studies in this area. Study on the left out of Hong Kong, study out on the right of, I think, over 300 patients in the COMET study, maybe 400 patients. So what you see is a consistent result. 2-year study on the left, treatment effect of about 0.15 diopters. COMET study, 3-year study on the right, and you only get, well, less than a quarter diopter of slowing of myopia, only about 0.1 millimeter slowing of axial elongation. But look at the COMET data down the bottom right. It's very clear that most of that treatment effect's in the first year. So even on a relatively ineffective treatment, you can think, oh, I'm doing some good in the first year, but you're just taking the parents' money to keep them in PALs beyond that because there's no different in the progression. So an ineffective treatment. Now, the investigators were fairly rigorous about analyzing their data. And as I said, they had a shitload of patients to look at. So when they divided the patients into 6 groups based on their phoria, whether they were ESO, ortho, or exo, and their accommodative lag, there was a suggestion that the treatment effect was greater in the subjects with accommodative lag and with an ESO posture. What they did was a second study where they only recruited those kinds of children. So this is over 100 kids randomized again to PALs and single vision. But this time, the kids to get into this clinical trial had to at least 2 prism diopters of esophoria and accommodative lag of over half a diopter. What did they find? Virtually the same as the first study. Okay, perhaps a more sustained effect, but there's nothing remarkable about putting a kid in a PAL just because they have esophoria. Study from Canada looking at executive bifocals with or without some base in prism. You can see maybe a 3/4 diopter slowing of myopia over 3 years and a slightly greater effect perhaps in the prism group. But when you look at the axial elongation, there's no difference with the prism group. But a suggestion here that executive bifocals are not only but ugly, but they may be effective at slowing myopia. Now, curiously, the Houston myopia study or the Houston bifocal study found no effect 20 years or 30 years previously. So this is the only or the best, greatest effect of bifocals. Now, most of our optical therapies are based on putting plus in the periphery. And I'm going to talk about the 3 groups here. And we know from a lot of very rigorous and beautiful work, including from my colleague Earl Smith, there's an underlying basic science basis about why we should care about the periphery. We know that if we have conflicting optical signals between the fovea and the periphery in an animal model of myopia, the peripheral signals will dominate. Okay? Likewise, if we put conflicting signals in the periphery, the more positive signals will dominate. The further piece of evidence that Earl Smith presented is that most of our therapies that are effective have a peripheral component. So let's talk first of all about orthokeratology. And the first study to sort of really rigorously show a slowing of myopia wasn't a randomized clinical trial, but Pauline Cho and colleagues showed that there was about a 0.25 millimeter slowing over 2 years with OrthoK. Look again at the data on the bottom left, you'll see that most of the effect is in the first year of the study. Well, Pauline and her colleagues did a randomized clinical trial and essentially replicated that result, about a 0.25 millimeter slowing over 2 years. Across continents and lens designs, the results for OrthoK in this meta-analysis here are remarkably consistent, okay, about a 0.25 millimeter slowing over 2 years. Well, what about multi-zone contact lenses? Now, the BHVI have done a lot of work. They published this paper a couple of years ago. They looked at 2 kinds of lenses, sort of a multifocal and then an extended depth of focus design. And they had 2 flavors of each of those categories. What did they find? Well, if you look at the control group in the orange on the right, and then look at the blue lines, which are the different treatment groups, there was about a 0.15 millimeter slowing over 2 years for all of those. And one of those lenses has now been marketed in Europe. Now, of course, the big deal in the US was the approval of the MiSight lens. And you can see here that you've got almost a 0.3 millimeter slowing and about a 0.75 diopter slowing of myopia progression. And again, as I said earlier, in these kind of therapies, you see a good correlation between axial length and refractive errors. So if you're monitoring patients in these lenses, I wouldn't consider axial length measurement to be mandatory. Now, finally, the Blink study was published last year. This was used in an off-label design, the CooperVision Biofinity. But what they had here was about 300 kids that were randomized to single vision, a medium ad, and a high ad. What did they find? The medium ad was ineffective. Very little effect over 3 years, worse than a PAL. But the high ad was more effective. So clearly we've got evidence here for a dose response. So more power should be put. What would happen if you went to an even higher ad? We don't know, because it could be a saturation effect or there could be additional benefit. But certainly the high ad was more effective here, but not as effective as the MiSight lens over 3 years. But it's another option you can have for your patient. Well, what about spectacle lenses? Well, the early attempts of putting plus in the periphery were relatively unsatisfactory. So the BHVI group looked at a whole host or 3 different kinds of essentially concentric progressive addition lenses. So you got sort of the correction in the middle and then increasing plus towards the end. The treatment effect overall over 12 months was about 0.05 millimeters, so not very good. But they did, in a subgroup analysis, found the younger kids with at least one myopic parent was more effective. The design was commercialized by Zeiss as the MyoVision lens, and then a group of Japanese researchers did an additional clinical trial. What did they find? Even if you recruit younger kids with at least one myopic parent, you got no effect. This is an ineffective therapy, which fortunately is unavailable in the US. Now, things changed a lot a couple of years ago with the introduction of the DIMS lens, the defocus incorporated segment lens, DIMS. And their 2-year data were very compelling. So over 2 years, they found about a half diopter slowing of myopia and about a 0.3 millimeter slowing of axial elongation. Another device that was in the use was sight glasses lens, these DOT lenses. Slightly different. They're not using refractive effect here. They're using a kind of diffusive blur, but they presented their results from a randomized clinical trial at the Academy last year, so we should maybe see these in print sometime soon. Again, they're sort of most effective of their 2 test lenses, slow progression by 0.4 and slowed elongation by 0.15, so that's about twice as effective as a PAL. ESSILOR came to the party recently and started talking about their Stellest lens, which is based on HAL technology. This lens has a series of concentric lenslets which have a spheric profile of between 3 and 5.5 diopters. The power actually varies across the lens and increases, or the ad power increases towards the periphery because you want to hit the further periphery harder. So they published earlier this year their 1-year results. And what you can see here is for the HAL lens, which is the highly aspherical lenslets, you got a very compelling effect. Then they presented the 2-year data at the ARVO meeting a couple of months ago, and they've got good retention of the subjects. But what you can see, this HAL lens, that's the Stellest lens, it's slowing myopia by 0.8 diopters over 2 years and slowing axial elongation by 0.35. This is, again, a very promising therapy. Now, finally, I'm going to talk about atropine because that's our most effective current option when it comes to pharmaceutical. The data at the top were from the original ATOM study, 400 kids randomized to atropine 1% or a placebo. This was a unilateral study. They didn't want to impair the kids, so they only treated one eye, but the placebo eyes progressed by a diopter and a quarter over 2 years. The atropine eyes only progressed by about a quarter diopter. So you got a treatment effect approaching 1 diopter. So they did another study, unfortunately without a control group, and they looked at 3 lower concentrations. And perhaps somewhat surprisingly, they found all of them were fairly effective, almost as effective as the 1%. Okay, so hallelujah. We've got a low concentration atropine that doesn't impair accommodation or dilate the pupil that much. That is effective. But there's a problem with the data. So here's the author's figure. figure, and I'm just going to focus on the first 2 years before the washout, you can see that on first glance, the refractive error and the axial elongation data look very similar. But when we look closely, so I'm going to show the placebo group in the first study, remember, is in green, and the 0.01%, the most commonly prescribed percentage of atropine these days, is in red. And what you can see that based on the previous slide that I showed you, consistent with that, you've got a slowing of myopia progression with the 0.01% atropine. You look on the right, there's no effect on axial elongation. So we've got a paradox here. And what we really need, of course, is additional clinical trials to untangle that. Which is correct, the refractive error data or the axial elongation data? One of the studies that was published, and this now is from the LAMP study in Hong Kong, and this was a bilateral treatment trial, 400 subjects randomized to those 3 concentrations or a placebo. You can see on the left the spherical equivalent data, on the right the axial length data, and what you can see is the nice dose response effect, with the 0.05 giving you a quite nice chunky slowing of myopia, or about half a diopter, and slowing axial elongation by about 0.2 millimeter. But if you look at the 0.01% atropine, it's relatively ineffective. It's slowing myopia by less than a quarter diopter over that year and barely touching the axial length. That's good.